this isn't my own skull. She's probably calling because she knows the babies didn't eat or something. The baby looks like she's eating her hand off. Oh.
You can pull up a chair if you want.
You can have a seat.
Yeah.
Okay.
I'm listening. I'm just putting
I hear
this in
ya.
the fridge. I don't know how long it's been sitting in there.
Oh, I'm fine.
Go ahead, Stephanie.
This is it?
Yeah.
That's it.
Okay.
I think that's all we're gonna need, yeah.
Okay, so for those of you who don't know me, because I'm not really around very much at night, I'm the physical therapist that works primarily in the NICU and on pediatrics. I'm also the therapist that usually comes over here to work with any babies that have a shoulder dystocia, brachial plexus, clavicle fracture. So tonight I wanted to talk to you guys about pain relief in the newborn. And we've known for a lot of years kind of what we're supposed to be doing, but really the question is what is the best thing that we can be doing for these babies and why is it effective? And the reason we're giving it to you guys, so I've given this to the NICU, day shift has had it, I've been here once before on nights. But you guys are doing a lot of painful procedures to our newborns. So what are the painful procedures? PKUs, eyes and thighs, blood sugars, heel sticks, diaper changes. Diaper changes. A diaper change is not inherently painful, but it is certainly not meant to be like a comforting procedure, and we all know no baby likes their diaper changed. For a baby with NAS, again, you guys may not see the red broken down bottom because by the time that happens, they're probably over on pediatrics. But that can also be painful. Plus, if they have diarrhea and loose stools, that's kind of acidic and painful on their bottom. And the physician exam, again, I had some physicians in the meeting in one of my lectures, and I actually gave this to the pediatricians throughout Chester County. Their exam isn't also not inherently painful, but it's certainly not pleasurable, comforting, which is really what babies are looking for, right? They're pleasure seekers. So this is my big thing, especially in the NICU, but it really does apply here for our newborn babies. Neurons that wire together, fire together. And you guys know that when a newborn baby is born, their brain isn't just like fully formed and ready to go. Things are still maturing, things are still migrating, and there's a lot of potential to do damage, and there's a lot of potential to do awesome, great developmental things for our babies. But what we talk about in the NICU, again, especially because our brains are really, really developing, is this idea that when these nerves are migrating, they have to go from point A to point B, and they need to find a path to get there. And so neurons that wire together, fire together. The best way I can describe it is if you think of heel sticks, right, which is probably the most common painful procedure, I feel like, in our hospital for babies. What we find is that babies with repeated heel sticks kind of learn to associate pain with anybody touching their foot. And so I don't necessarily see enough babies here on your unit, but I know that when I see premature babies who are getting lots of heel sticks, what I find is when I start to do massage, they kind of truly really get into the whole massage and they relax and they calm and they're great. When I get to their foot, they usually have like a pain response. They usually pull back on their leg. They usually have increased heart rate, increased respiratory rate. Sometimes their oxygen goes down. And I've done nothing except massage their leg and get to their foot. And so what I teach parents to do is really to just hold the foot, like give some positive input, do a little massage to the foot. Because basically that baby's pain response has been wired to someone touches my foot, then I get pain. And so those pathways are firing together now. So that's going to create an abnormal response at that heel. And that's just like one example. But again, it can happen really with anything. It can happen with a diaper change. And so I'm not going to go crazy on the neuroanatomy with you guys, but I just kind of wanted to give you like a background. When we get some sensory information, the amygdala is the piece that interprets that information and decides, is it pleasurable? Is it stressful? Can I stay here, or do I need to ramp up my system and decide whether to fight or flight? Okay. The amygdala then is sending whatever information it deems appropriate to the hippocampus, and the hippocampus is responsible for memory. So it's going to assign a good or bad memory to that response. When someone touches my foot, it's a bad response, it hurts, and so now I'm going to store a negative memory to anybody touching my foot. Okay, does that make sense? Okay, so that's kind of really the gist. So nociception is really that whole pain response. And I feel like back in the day we used to say babies didn't feel pain the way we feel pain, or that's why it's okay to circ them with like nothing, But what we know now is that pain systems are present in early fetal development starting at 20 weeks. So at 20 weeks, babies can start to feel discomfort and pain. And what they are finding is that this early activation of pain, whether it's in the newborn or the premature baby or whatever, can lead to long-term alterations in sensory perception. And also in the perception of pain. It can have like a heightened response to pain or like a dulled out response to pain. And what they found, they've done a ton of MRI studies, and they were showing that infants who experience pain are actually using different pathways when they get touched than babies who aren't getting a lot of painful procedures done. And it really does lead to long-term changes later on in life. So I should just tell you guys too that besides being in the hospital and working with the babies here, I run our developmental follow-up clinic. So we see babies, if you guys have a high-risk baby here and I'm seeing them, sometimes I will sign them up for clinic. Some of the kids on pediatrics, a lot of them are the premature babies. We see them every 3 to 6 months until they're 3 years old. So I really can see kind of what's happening to our babies from where they were in the hospital to what they look like when they're 2 and 3. And do any of you have children? Okay, so you guys have probably been in schools. You guys have probably heard the buzzwords like sensory integration dysfunction, auditory processing dysfunction. There's a lot of behavior issues that come about, and a lot of it comes from impaired sensory perception. We have a much higher rate of autism, of sensory processing issues in our preemies who are getting constant painful procedures. Again, I know they're not here long enough for you guys to give them constant painful procedures, but a lot of the stuff we're doing here is not comforting. And so if we can make it any better for this newborn life, that's what we really want to do, okay? So we know now that infants actually perceive pain similar to adults. And this is actually a really cool study. If you look at the MRI of an adult and the MRI of an infant, okay, they did the same painful procedure on both an adult and on an infant. And what they found is that basically 18 out of 20 of the brain regions that were active in pain were active in babies as in adults. Trish, are you okay? You want me to continue?
Go ahead. Is that baby alright, Paul?
You did not like that.
Oh, the sweeties.
Yeah.
Barfing up sweeties from the start.
Okay, so 18 out of 20 pain locations in the brain were present in the infants as they were in adults. So basically, that's like practically equal, okay? So we know from our MRI studies, babies are perceiving pain exactly the way that we would perceive pain. It's not acceptable to say anymore, they're babies, they don't experience pain. We know better now, okay? And you guys, I'm sure, all know that when a baby's in pain, they have increased heart rate, increased blood pressure, increased respiratory rate, and they usually tend to have increased muscle tone. Behaviorally, you see screaming, crying, typically crying in a baby, screaming in a toddler. And what happens is that as this repeats over and over again, the baby decides to do one of two things. It can either be hyper-aroused or it can totally dissociate. So hyper-arousal or hypersensitive infants become overly distressed during a procedure that's not even necessarily so painful. But what they've learned is that someone who touches me could possibly hurt me, and so they're just on edge and they're on alert. Whereas other babies can become dissociated, whereas they're going to just tune everything out. And so the minute somebody comes and they feel someone on that heel, they're going to totally shut down. And one of the biggest problems for that is actually bonding with parents. If they learn to associate a person coming to be with me and they're going to automatically dissociate, that's not going to do a lot for parent-infant bonding. Okay, and really what our babies are experiencing is all the stuff you hear in the news about what we adults experience. Like, what does stress do to our bodies, right? It causes heart problems, it causes high blood pressure. If you have chronic stress, you get emotionally distressed, you have poor nutrition. And what happens is it increases our glucocorticoids. And that is actually a finding in a lot of kids with ADHD who are also like hyper alert and hyper aroused. And it changes the brain and it can lead to decreased attention, memory, perception, learning. So really these kids are going to school already at a deficit. So the biggest piece here that I want you to know is that when we get stressed, so think about when you're in the mall and you lose your kid. You know that like adrenaline response that you feel? Okay, that's your sympathetic nervous system. That's your nervous system that says, do I need to fight this? Do I need to fight this? Oh my goodness, something is going on, and it floods your body with adrenaline. That's the sympathetic nervous system. Okay, the parasympathetic nervous system is your calming nervous system. That's what calms you down. Okay, so you have two opposing nervous systems in your body, and so do babies. Now babies, because they are born pretty much helpless, they are predisposed to that sympathetic response. Like think caveman times, right? Like they needed to have an increased heart rate, an increased respiratory rate versus that calming down response. They didn't need that as much. We're talking about like survival of the fittest, okay? So our babies are programmed, all of them, for that sympathetic response. So when they get a stressor like pain, they're gonna automatically do that high heart rate, high respiratory rate. Okay, medications. Why aren't we giving medications for our vaccinations? Why aren't we giving them for our heel sticks? So again, according to the evidence, what they found is that topical anesthetics like the Emla cream or whatever are effective for pain during circumcision, but they really were not effective for heel sticks, inserting IVs, things like that. Opiates, I know it probably seems like totally a little overkill for like to give an opiate for a vaccination, but and clearly we're not going to do that. There's clearance issues of opiates within the baby. Dosing is a challenge. And even Tylenol, like thinking we could just give the baby Tylenol before we do a painful procedure. What they found was that was actually not as effective, it was as effective as a placebo. So truly it was really not effective for pain relief in IVs. So you guys have help on your unit because your moms are here. And so the biggest key here is to involve parents. And you guys know all the stuff that's coming down from Penn. We really want to involve parents. We want to improve our patient satisfaction. The more you educate parents and the more you get them involved, they're going to be happier and more satisfied with our care, and they're going to bond better with their baby, even if it is an unpleasant thing like they've got to hold their baby during a vaccination. But the other piece is that if you teach them what to do now, you know they've got like many pediatricians appointments coming up. They've got many vaccinations. You know someone's going to break a bone or somebody's going to need stitches eventually. So you're helping moms learn how to calm their baby down. So giving them the control to calm their baby is really empowering, especially for a brand new mom who's probably really scared and stressed. It helps them bond. Studies show babies know their mom's scent over any other new mom scent. They will gravitate toward their mom's breast milk smell over any other new mother breast milk smell. They know their moms, they know their voices. I tell the parents all the time, your baby knows your voice the best, and it probably knows your partner's voice the second best. So when you talk to your baby, it's going to be calming, more so than when I talk to your baby. I know there's some hesitation because I think, there are definitely certain parents that have some anxiety, and they may say like, oh, I don't want to hold my baby. I don't want them to associate me with a painful procedure. So there's really no studies that show that happens, that a mom being present gives a baby like a bad taste in its mouth or something. Really what the baby feels is that love and that warmth and that calming. So again, if you have a hyper anxious mom and she really is getting upset, I probably wouldn't push it. But if you have a mom who's not really sure, kind of like throws that out there, educate them. Give them the, not this whole in-service, but say, you can calm your baby down the best. It's going to be better for your baby, and there's no evidence to show that your baby will associate you with pain. So allow them to be a part of the procedure. Okay, so I did a ton of research for this to really find out what is the most beneficial pain reliever. And truly the best thing that you guys can do is have the parents do kangaroo care or breastfeed their baby during the procedure. So breastfeeding it was the best. Breastfeeding reduced basically cry time. And what they found is that breastfed babies cried for 38 seconds less during a painful procedure than babies who were not breastfed. And you guys know, you all have kids, like 38 seconds of a baby crying feels like 38 minutes to a mom. So that is a really significant number. If we can reduce that amount of cry time, I think parents will feel so much better about their baby getting whatever procedure is being done. The way it works is that kangaroo care, skin to skin, releases that oxytocin, that feel-good calming hormone. They suggest that kangaroo care is done 30 minutes before the procedure, and then the baby stays on there for 10 minutes after. And I know you don't always know when you're going to run in and do the procedure, but if you have some idea, even putting the baby on probably for about 15 minutes, let the baby settle in and do the heel stick. Sometimes the baby doesn't even know that you've been there because they're so calm and warm and listening to mom's heartbeat. The second best pain relief. The second best pain relief really is a combination. It's a combination of non-nutritive sucking, which is basically sucking on a pacifier or something else, swaddling the baby, and doing a facilitated tuck. And we're going to talk about all three of these things. But the deal is that the best response is using all three to get that synergistic effect. Okay? What they found is that babies slept through painful procedures. It reduced fussing times. It reduced crying times after the fact. It minimizes state changes. We look a lot at state changes up in the NICU and with our NAS babies. But if you have a baby from total full-on sleep to going to crying to then being like hyper alert, those state changes are really not good for a baby system. So reducing the state changes is really helpful. And there's less recovery time because the baby's already calm and stays calm during the whole procedure. So sucrose, some babies maybe don't like it so much and choke on it, but you guys have the sweeties, the purple bullets, okay? It's 24% oral sucrose. You want to give it 2 minutes before the procedure. And I know if it's anything like up in the NICU, like when they come to do the circ, they want to come and get that circ done. If you can get that sucrose in and hold off the doctor for 2 minutes, that's where the highest effect is going to be, okay? So sucrose, 2 minutes, and then really it potentiates after 5 minutes. So if the doctor hasn't done their procedure or you haven't done your procedure, you can give the baby another dose to help keep the baby pain-free. Sucrose works by releasing endorphins. That's kind of like what you hear like with a runner's high, like when people get addicted to running. You don't want to give it every hour on the hour. Giving too much sugar to a newborn baby is not ideal. But again, you want to use it for painful procedures. Any questions so far? Okay, non-nutritive sucking. So I know we're baby friendly, but I also know that we're allowed to give pacifiers for painful procedures, so definitely use them. But if you need to do some other kind of non-nutritive sucking, you can have baby suck on mom's pumped breast, or honestly, for a lot of your moms, they're not even making milk yet, so you can just have the baby suck on the mom's breast. And if milk comes out, that's even better, because again, that was like that #1 pain relief. You can use a finger. I tell parents if they're going to use their finger for non-nutritive sucking, if they have just recently Purelled, they should put a glove on, because that Purell is total alcohol and it tastes horrible. I do a lot of stuff in the NICU with babies with their hands to their mouth. So you can actually put the baby's hand up to their mouth and let them suck on their hand. There's a lot of receptors around the mouth, a lot of receptors in the hands, and that actually facilitates better feeding later on as well. That's kind of like a nice side bonus. But letting the baby suck on their own hand is also a good way to get non-nutritive sucking in. And again, you know, if you use the pacifier, you're supposed to take it out when the baby goes back to the mom. Okay, so facilitated tucking. You can see a really great example of it with the baby on the top, okay? And really all it is you're keeping the baby in flexion in that quote-unquote fetal position, right? You want to make sure your hands are warm. Rub them or put them under warm water if you need to. And really, you're reminding the baby of what it's like to be in utero, right? So if a baby was in utero, it would have boundaries and borders everywhere. It would be super, super flexed. And I tell all the people that I'm teaching this to, like, when you feel sick, like when you have the flu at home or your kid has the flu, do they lay in bed like this when they're feeling really crappy, or are they all pulled in? Okay, so we kind of go back to that fetal position, and that flexion is a calming thing for a baby. So bringing the hands together and bringing the hands up at the face, eventually this is a self-calming thing for a baby, but a newborn and a premature baby don't necessarily have that ability quite yet. So helping the baby bring their hands to their face, putting their hand on their head, right, because most babies are upside down, so there's always pressure on their heads when they're in utero. This is a really calming thing for a baby. And just helping the baby know where they begin and end in space is going to be a really calming thing. The other big piece is which system, sympathetic or parasympathetic, is the calming system? Parasympathetic, okay? And again, our babies are not really predisposed to parasympathetic nervous system activity. We have to facilitate it. So one of the coolest things I've learned is that apparently, and again, if you think about what we do when we don't feel well, we think about what position does a baby sleep the best? We're not allowed to put them there. But they sleep best on their bellies, right? So we have all these parasympathetics that run from below our nose all the way down the front of our chest, all the way down the front of our stomach, okay? And they're kind of like close to the surface. So if you can facilitate, we call it ventral support, you can facilitate any of that support on a baby, you're gonna help activate the parasympathetics. And again, you wanna be careful, right? Like you're not gonna be like, the baby has to breathe, that's important. So it's really, you know, we teach parents this all the time. I just actually had a baby with NAS over on PEDS and I was doing it with a mom too, and baby calmed down immediately. But it's really just kind of like a little bit of pressure right here. And when I turn babies, I'm always giving them ventral support. When I'm moving a baby to like weigh it, I always give it ventral support. Handling all those transitions is gonna be a lot easier if you can help facilitate that parasympathetic system, okay? So the tucking part and keeping them swaddled or whatever, what is the reflex that makes babies startle? What's it called? The Moro, right? And so we know babies that are swaddled, if they start to startle, the swaddle helps them bring everything back in, right? So again, when you're doing a diaper change, and you can, especially like a baby who's had a fresh circ, or a baby who has horrible excoriation from NAS, what I usually do is I will wrap the arms up in the blanket, totally swaddle the arms, and this, not the face, and this baby's elbows don't bend, so it's a little hard, and then I leave all this open to do the diaper change, okay? Again, you limit that Moro, the baby is calm, hands up at the face, and your diaper change is going to be a lot easier. And again, for NAS babies, this is like a godsend, especially with a pacifier. And if you have a second person, this is one of those things that you can teach parents. Here, you hold the arms while I do the legs, and watch how much better she tolerates her diaper change. Or, you know, and especially the baby who had the fresh circ. The other thing that I have talked to the nurses about upstairs is the best position to do a painful procedure is on a baby's side, okay? This is a very exposed, being on their back is a very exposed position. It does not feel comfortable. We talked about it. When you need to feel comfortable, when your kids feel comfortable, they curl up inside, they curl up into you, right? Side lying, if you can do it, is the best position for a baby to get a painful procedure, okay? And again, if you were gonna do a heel stick, I would wrap everything. Like I would wrap this leg, I would wrap this whole baby up and leave this out if I needed to, okay? Or again, have mom. Mom can do containment at the other foot, mom can do containment at the hands, okay? Let's see. Okay, some other things. The lactation consultants have really, like, they love to use the idea, they like the idea of using breast milk over the sucrose, right? Breast milk is more natural. Sucrose is sugar. We wouldn't give our kids sugar. The studies are like kind of, some of them show that breast milk actually does have a pain relieving response, and other studies are showing that it's really no more effective than water or a placebo. I would say that sucrose is probably the most beneficial, but breast milk does have high levels of tryptophan, and tryptophan is in like turkey on Thanksgiving, and at the end you feel like full and relaxed. But again, studies are really inconclusive at this point. So I'm putting it out there. If you want to try it, it's worth a shot. If you, for some reason, you don't have sucrose on the unit, or the mom's really against it, but they don't really know how beneficial it is at this point. But again, if you're going to use the breast milk, don't just give the breast milk. Give the breast milk with a pacifier and do the tucking or the swaddling. Okay, you need to do all of them. Holding and rocking. If a mom is, I don't know how, because I feel like once I had a baby, I was very like out there. But if a mom doesn't want to do skin to skin, if they're modest or they don't want you to see anything or whatever, if they don't want to breastfeed, even just swaddling the baby and having mom hold it, the baby will tolerate the procedure better. And we went around we did a bunch of different things. We did it actually with a baby breastfeeding. We did it with a mom holding, and we had the baby fully swaddled like I had this one before, with the heel out, and mom was holding the baby, and the nurse was underneath, and the nurse did the heel stick. The baby didn't even flinch. What's awesome about this position too, if you have to do the state testing, is it's to gravity. So you don't have to milk that heel, milk that foot. You have gravity helping you. And so what we were finding is that if we were doing it when a mom was kangarooing, or we were doing it when a mom was breastfeeding, or even just holding and rocking, by the nature of the baby being elevated and calm, because think about it, when they're stressed, their muscles constrict and tighten. You're not going to get good blood flow if you're trying to get blood from a baby who's stressed. It was taking us so much faster. It was much less time to complete the whole thing than if we had done it laying flat with minimal pain relief, or just like some basic pain relief. And grasping, that's the other thing. So we talked about babies hands to face, that's a calming thing, and grasping is a calming thing. Parents love to let their baby grasp onto their finger. So some of our preemies, that's the first thing that they'll do to help with state control, to help relieve stress, is grasp onto a finger. And you will see their heart rate and respiratory rates regulate if they're already stressed. So like I said, I really did a ton of research on what the recent literature is showing. And truly, it's that parent involvement, breastfeeding, holding, kangaroo care that's going to be the best in terms of pain relief. And I will say I had some really great feedback from the day shift nurses who, I mean, they've had it, like 3-4 weeks ago, so they've had a chance to process it and trial it. And I've gotten great feedback that they were doing more procedures in the rooms. They were letting parents hold and breastfeed and do whatever, or even just, do the containment with the baby laying in the crib. And they've had really positive feedback from parents, and then I got positive feedback from nurses. And I did, like I told you, I did do this in-service for our pediatricians, because I have a feeling that our parents are going to be leaving here with some of these skills, and they're going to go to the pediatrician's office and say, like, okay, I want to breastfeed while you do the vaccination. And a lot of them, they're not really set up for that, or they haven't really thought about that. And one of our nurses in the NICU, actually, she just had a baby, and she asked her doctor if she could breastfeed while he was giving the vaccination. They're like, oh no, the baby has to be flat in the bed and whatever. So they're probably a little slow to come around, but I wanted them to hear what we are telling the parents, because when the parents go there, they're probably going to repeat some of it. So that is really what I had to offer you today. Do you guys have any questions or comments or concerns? I mean, do you guys mostly do the procedures here in the nursery? You do both.
I mean, the circs obviously are done.
Yeah, yeah. And the circs that's really a whole different ball game. But again, I would definitely give sucrose. And we talked a little bit about circs before. My son had a bris, so his circ was done in my kitchen. But it was amazing because the doctor was really, this was like 14 years ago, and he made me prepare a bottle of sugar water. He put that Emla cream on, and that Emla cream like stayed on for a long, long, long time. I don't know if they use it here. No lidocaine. He was like, the lidocaine, it hurts just as much as the circ. Like, so what's the point? He did a really amazing job, and there's definitely some things we can do to work on the circumcisions here. But again, I clearly would not have a parent. I didn't want to watch my kid's circumcision. Like, you're not going to have a parent watch or hold or do anything like that for the circ, but for some of the other painful procedures, for sure. And again, the right kind of parent. Like, there are definitely some parents that have some psych disorders or whatever, and maybe they can't handle that, and that's okay too. But again, the biggest piece is that just give them the education about how beneficial it is and empower them how comforting you, mom, are more than anybody else in this unit. Like, you're going to be able to do that the best. So, all right, well, I'm going to be here for a little while. If you guys have any questions, I'm happy to answer them. And thank you. I know it was a crazy start to your night, so I appreciate you guys sitting through this.
Thank you, Stephanie.
Yeah, sure, no problem.